So we know Black and Indigenous women have more severe symptoms, earlier onset of symptoms, yet struggle to access the same level of care.
What resources might they have, specifically with menopause care?
Actually none that I know of. Their health is not always the first priority, so they will take a day off work to take their child into the office. But for themselves, they may not be able to do that, and they become the last person that they care for, despite being the caregiver for so many people.
There are people who will create the solution, but that solution needs to be paid for by someone, that the someone is the patient.
Suffering is not an option anymore. I think sexual health is health. Let's talk about it. Let's normalize the conversation and understand that by addressing it, it can improve your health overall.
What can we do?
It starts with us as family doctors, and it is our responsibility to learn, and I do see that changing.
I'm Dr. Beatrice Seguin, PhD, and you've landed on my podcast this time of the month, your trusty sidekick to the midlife roller coaster. I chat with experts digging into legit solutions for midlife hurdles, be it health or lifestyle. Ready for the ride? Dive into this time of the month. Subscribe and catch the latest episodes on our channel. Let's own this midlife magic together.
When we started the show, there wasn't much information for the average person about menopause, but now we're drowning in content. Yet somehow, so many women are still left out of the conversation. In this episode, Dr. Sheila Wijayasinghe helps us cut through the noise. We talk about why menopause care isn't one size fits all, the growing FOMO around hormone therapy, and how to make choices that work for you. What equity in care really looks like, and who's still being left out. We're going to talk about practical ways to access care even if you don't have a family doctor, and how family medicine can and should handle menopause, and why being gentle with yourself might be the most important treatment of all. Dr. Sheila is a menopause-certified family physician and a sexual health advocate. She's based in Ontario, Canada. She leads primary care outreach at Women's College Hospital, contributes regularly to The Social on CTV, and is a co-host of her own podcast, The Doc Talk. Her work centers on accessible, safe, culturally acceptable, evidence-based care. Dr. Sheila, I'm so happy you're here. I remember the first time I saw you speak in person, not on TV. It was at the National Menopause Show in Toronto, and there was something so special about you. I have to say it. There was a humanity in how you spoke about a biological phenomenon. And it made me feel safe to approach you. That is why I approached you,
Thank you for
if you
coming.
recall.
I appreciate that.
Yeah, it really made me think. It made me think of my sibling and other people who are marginalized and who don't have access to care. So we're happy there is a menopause moment and a lot of awareness. But I feel that you're a person who can, help us unpack why we still need to continue the work.
I'm so grateful for the opportunity to be here, and I appreciate you saying that. That is really why I went into medicine, is to be able to help people feel safe and cared for and nurtured. I saw in my own family life when I was young, my parents experienced significant discrimination in the healthcare system at a time that they were at their most vulnerable moment. And I was 7 at the time, and I remember that so distinctly. And that is why I went into medicine. It is why I do what I do, to just be a space for people to come feel safe and help them navigate a system that unfortunately is not safe for many. And that's really my role as a family doctor, is to support them through those journeys in those most vulnerable moments, see them for all the levels of who they are. Mm-hmm. It's sometimes we tend to distill people down to their diagnosis instead of seeing them as their full self, as their role as a parent, as a child, as someone who is in the peak of their career or starting out. And I see that as a family doctor. And then I also see the challenges that they may face in terms of the discrimination that they may face because of their race, their sexuality, all of these other pieces. And really that's our role as family doctors, is to see our patients and to help them be cared for and to feel safe and navigate.
So what have you learned as a family physician in because I think sometimes we don't realize what we don't know, right?
Yeah.
So if you're in a situation where you haven't been accessing care, and I don't mean you have a doctor, but you're not accessing what you need, what are you doing to help that patient? How are you extracting the information so that they get what they need?
So this is really interesting. So access to care is not just your ability to have a health card or to even have a doctor. Access to care means that you're able to feel like you belong in our healthcare system, and that's barrier-free. And a lot of the work that I do at Women's College Hospital in the outreach sector is really around meeting people where they are and understanding that we all may start at different places in life, and that is going to affect access to care. So you may not have transportation to get to your doctor's office. You may not have the money to pay for childcare, to take time off from caregiving to come to see us. You may not speak the language that your healthcare provider speaks. And so it's understanding those specific barriers and then figuring out how to get rid of those barriers, which is not always easy. You know, we are, as family doctors, we're very strapped for time. We have maybe 10 to 15 minutes with our patient, and being able to understand that is not always easy, but there are ways to do that for our patients. And so what I do is, so one of the things that we do, especially in the menopause space, is recognizing that there are many people who are left out of the conversation, who suffer with worse symptoms than the rest of the population. So we know Black and Indigenous women have more severe symptoms, earlier onset of symptoms, yet struggle to access the same level of care. So one of the things that we did at Women's College is we just started our new Indigenous Menopause Outreach Clinic, where we are taking menopause care to the community. And so we are working, understanding that the healthcare system is inherently violent to some patients because of historical issues, and we are a systemic system, and there's racism that exists within it and other issues. And so what we did was we built trust with a community. We co-designed a program alongside elders and the teams that work with this community specifically to find out what the barriers are. And instead of expecting people to come to the hospital to get care, I go out to the community, I meet with people on site, and it's been such a beautiful experience where people are getting care where they feel most safe. And it's been really lovely to kind of see people open up, but also we work within what's comfortable for them culturally. And so last time I was in clinic, my last visit, I had 3 patients in at the same time because they wanted to come in together for their appointment. Culturally, there's a community that is such an important part of how they feel safe. And also because I'm a healthcare provider, I represent the system, and so they felt more safe coming in together. So it was really beautiful because the 3 of them came in together, and it was actually quite joyful because they joked around a little bit. They're like, tell Dr. Sheila about your vagina. Tell Dr. Sheila about what you told me last time. And I just had to switch between charts and I was like, are you okay with me talking and asking questions? They're like, oh yeah, we talk about this on the couch all the time, like this. Let's open up the conversation and help each other, which is, we know that social connection is important for our health. And I'm like, why can't we do this more? And so we learn a lot from these populations that are often dismissed. And I think we can take those learnings and think about how do we make care better for everybody as a result.
I love that learning. Were there changes or resistance within the establishment to say do that? Because you have 3 people, 3 charts. I
didn't ask permission.
You didn't ask permission.
So I'm fortunate in that because it's a program that I work to support with the community. They're very open, and I really appreciate that about Women's College because they are innovative and they want to really go beyond the boundaries of the hospital in offering care. And so beyond this, we're looking to expand the program to support other individuals who may be left out of these conversations. So we talked about maybe we need to do more remote work to reach the northern communities that we're not reaching. That's an area that, like specifically, that is really lacking in access to care. We want to do more in terms of incarcerated women who are often left out of the picture, so that is something that we're looking at as well. I'd really like to go into the shelter system and work in the shelter system, specifically doing consultations around menopause. And I think sometimes these populations are left out because they're, we ignore it, and we don't expect, this isn't important to them. But I think to myself, somebody who's suffering with homelessness and having hot flashes at the same time and sleeplessness, all of these things contribute.
Which can be alleviated.
Yes, exactly.
So take that
There's something
off
that we can do.
as
Let's
a stressor.
reduce the burdens that you're already facing. We have so much potential here to do more work in this area. And so that's where equity is really at the center of what I love to do, and it really lights me up. I love working with my residents and medical students. The future is really bright. Like, I think when I see my students, they're all really interested in this as well, and finding ways to reduce the barriers, help people feel safe, and reach out to the populations, the equity deserving groups that really are left out of the conversation. There's so much more that we can do, and I'm hopeful that that's coming.
By sharing this, it also shows other practitioners that it can be done. Is it onerous, or is it just a mindset?
I think it does. There's practical considerations for all of these things that we have to think about. I have the beauty of that my position is a salaried position, and so I can be flexible and go out to communities and do this work in a way. But we talked about this before. There's no specific billing code for menopause, and so for other practitioners to do this, they have to have that flexibility because it's a livelihood too. Like there needs to be some way of discussing those things and also allowing us to be flexible in our workspaces. You have to be comfortable going out into community. We are socialized in medicine to be seeing our patients in a clinic space or at a hospital space.
Yes.
And so going out to a community,
have a certain distance,
right?
yeah.
We used to wear our white coats. Like, there are these things that we used to do, but still do, to feel comfortable in our healthcare settings, and it can be very sterile. My previous role was as medical director of the Immigrant Women's Health Center, where we had a mobile clinic. It was a big pink and white Winnebago, and we would take that around the entire GTA, around Toronto, to different communities. So we'd go to factories and English as a second language programs and work with communities within the communities. That was my favorite day of the week because we were out in the sun working with communities. There was music and there was food, because food is a big part of bringing communities together. And we would do pap tests and talk about contraception and sex and all of the things that in some of the communities we went to, those were taboo subjects. We would come in as a cancer screening bus. And then we'd use it as an opportunity. It's a nice segue into saying, we're going to talk about sex, and we're going to talk about what's happening at home, and how can we counsel you in contraception and other things that often were left off the table in those ways, and they didn't necessarily feel comfortable talking to their own providers. But those are really wonderful times. The bus doesn't work anymore. I'd love to revitalize that. But it's really like, those are the moments that we were out in the community providing care, especially when it came to pap testing and cervical cancer screening. These populations were under-screened as well.
We didn't spend too much time on non-binary trans community members. What resources might they have, specifically with menopause care? I don't know that there are many, but can you share?
There are not many.
Yeah.
There's actually none that I know of. I've looked this up because I do have a large non-binary and trans practice, and it's a wonderful part of my practice. Like, it's such a joy to be able to do this care, and it's gender-affirming care. And the challenge with menopause, and how we describe it, is often puberty in reverse. And puberty is a time that is fraught with a lot of gender dysphoria, because it's a time where our bodies are changing, and there's feminizing changes and masculinizing changes that, if you are trans or non-binary, that can be very difficult. And so really what we do in our practice is, when people are approaching that time, and the challenge is that depending on their surgical history, if they've had surgery or not, if they're on hormones or not, because again, not everybody is. And that can change how their menopause transition is. So it's a very one-on-one conversation. There's no one picture. That's why there's no guideline around this specifically at this time.
Right.
So I have to sit with my patients and I say, listen, I change the terms that I use to make sure that they're comfortable with the words. I don't say local vaginal estrogen treatment, for example. I say local treatment with estrogen. And we talk about, I always ask, because I'm learning also all the time, and I say, listen, I want to make sure that the terms I'm using are comfortable for you, and so I'll ask up front, and I'll say, you might experience symptoms of discomfort with sex. Is that happening? This is the treatment that we use. This is what we know about it. And then we talk about it, and then we do close follow-up. So it isn't, right now, there's no guideline around this because it's individual. But I do think it's an area that we do need to focus on. There needs to be more research in this area so that we can ensure that menopause care is equitable for everybody.
We tend to make assumptions, right? We're so used to it, if you are more of a office worker, let's say, where you can take time to go get your test, but there are different settings where that isn't possible for many reasons, including the actual working schedule of someone. So I think that is, we need that bus revived.
I know, right? And I'd love to do that, but we think about, just like you said, people taking a day off work or a half day of work. Doctors work the same hours that everybody else works, 9 to 5. We're not very convenient. And then you have to get transportation. And then maybe if you're driving, you're parking. Wherever you go. There's costs and costs. And a lot of patients, cost of living is really high right now. It's expensive. Groceries are expensive. People are working 2 or 3 jobs at a time, and then expecting them to be able to come in and see us is very difficult. And so, and especially for women, I find that their health is not always the first priority. So they will take a day off work to take their child into the office or support their loved one or their aging parent in. But for themselves, they may not be able to do that, and they become the last person that they care for on that plate, despite being the caregiver for so many people. And I understand that because it's costly to come in. So again, we have to find ways to reach people where they're at. Otherwise, we're missing a significant proportion of our population who really do need that support, and there is support available.
And we'll talk about some of the specifics of what the support is, but I'm still, my mind is still when you said there's no billing code for menopause. That's mind-boggling that in 2025, a physician cannot, and that is how it works, right? That's just the reality. If there's not a code to which you can attach the care, you don't get compensated.
Yeah, so we work around it. So we use other names. So we'll say amenorrhea, which is not the lack of periods, or we'll say ovarian dysfunction, or something along those lines, and try. But what we really need is a consult code for menopause that really allows us to, and really firmly places menopause care in primary care. So for family doctors to be able to do this, just like we care for our patients for diabetes. And there's diabetes codes for when I'm seeing my patients for diabetes. We have a flow sheet. I get to bill for that flow sheet because it really makes me responsible for all of my patients for all of their different health conditions. Menopause isn't a health condition. It's a natural stage of life, but the consult does require more time.
Well, I think because we've traditionally built models of care around diseases, but not models of care around, in this case, menopause. And so we don't have a model of care. And I think that's really lacking. So what are things that I think that's when we have to ask our public policy institutions to change that.
Absolutely. And I think that's where we're advocating for that. So there's a large group of family doctors and specialists who are really trying to make those changes happen. We're writing to our politicians to ask for these changes. Change comes slowly, so we'll continue doing the work while this is happening.
Of course.
But I do think that those things will make it easier and increase access to care in the end, because more family doctors will be able to see this as another visit, reason for people to come in, and for us to be able to see our patients just as we see them for diabetes or heart failure or anything else. A menopause visit is really what's needed.
And it's not a one and done.
It's not a one and done.
It's something that requires longitudinal care,
Yeah, so diabetes, we see our patients every 3 months, and we fill out the flow sheet, we do that. Something similar to that for menopause. Often when I'm seeing my patients for menopause consults, because we started a menopause consult service for our family practice team at St. Mike's. We have 50,000 patients in our family practice team. It's very large, and half of that population are people who will go through menopause. And so two of my colleagues, we started a menopause consult service for that, and we're just seeing our patients in that way. But we do a long visit to start, and then we do a follow-up visit in 3 months, and then if needed, we do another one in 3 months, very similar to diabetes. And so ideally, we'd have a billing code for it. We just don't yet.
We'll get there. You touched upon the fact that, menopause care should really be, part of primary care and family physicians. And I've noticed, perhaps because now there's this intense menopause awareness on social media, and you have a lot of, let's call them gynecology experts, and then it creates a perception in women that to get good menopause care, I need to see a specialist, a gynecologist. Walk us through that, because it's not necessarily nor tenable. How many gynecologists compared to how many family physicians are there in Ontario, for example?
You're right. So if we're going to think about how are we going to improve access to care for menopause, it really doesn't. It starts with us as family doctors, and it is our responsibility to learn, and I do see that changing. So I trust that this is going to change in the coming years. But the truth is that like our specialist clinic in Toronto right now for menopause care takes 3 years to get into. And I don't want my patients to be waiting 3 years and suffering through those symptoms when we have the tools available to us as family doctors to do this care very well. And I'll tell you why family doctors are well equipped for menopause. Menopause is a symptom, like multiple symptoms, as you know, that we can manage very well. But menopause in midlife specifically is a time of great change where your heart disease risk factors increase and your bone health risk factors increase. And that is family medicine. We manage heart disease, and preventative care is the hallmark feature of primary care or family medicine. So that's with family doctors or nurse practitioners.
Yes.
And we are able to do that. And so when I see my patient, I'm not just seeing you again as hot flashes. I'm not seeing you as just someone who's coming in for vaginal dryness or for brain fog. I'm seeing you as your whole self, and I want to protect your heart. So I'm going to be checking your cholesterol, your blood sugar, your blood pressure, and going through the lifestyle changes that we need to do to protect yourself as much as possible. I'm going to be looking at your scores for your bone density and figuring out, I know that you have a family history of a hip fracture in your mom, which puts you at higher risk. And by knowing that, because I see you over time, my relationship with you is comprehensive and it's longitudinal, so it grows over time. I know your risk factors and I'm able to better support you. Like, who better can do this for you than a family doctor? Yeah. So I'm going to manage your symptoms, but I'm also going to support you as you navigate midlife. And mental health is the other piece. Like,
it's a huge piece.
The majority of the care that I provide, I run out of tissues in my office very quickly. It's very interesting because I'm always refilling them, because mental health, especially post-pandemic, we went through a mental health crisis during the pandemic, and I'd have to say, we didn't expect to see that continue on, and it is still persisting through years later, that people are lonely, mental health conditions increase, and especially in midlife, we see that happen. So again, heart disease, bone health, and mental health conditions, we are so well equipped to support our patients, and this is something that I really firmly believe menopause care is primary care, and we can do this.
I know there traditionally wasn't a lot of menopause education in the medical school curriculum. Is that changing?
We're working to change that. So I just gave a lecture to our residents, so our family medicine residents. So once you finish medical school, then you have 2 years of family medicine residency. And I gave a lecture for our 30 residents at St. Mike's, and they were so keen. And it was a 3-hour lecture. Well, I wasn't taught very much in medical school about menopause, very little. And actually what we were taught in medical school, because I graduated in 2004, and the Women's Health Initiative came out in 2002, which overnight changed how we cared for women in midlife. We were taught basically don't ask, because we don't have safe options for women at this time. And so if you ask, then you have to, we're taught in medicine to ask questions only if we can help you with some sort of intervention.
Yeah.
And so at that time we were taught, please don't ask because we're not going to be able to support our patients through this. And so it was really tricky because that was what we were taught, and generations after me were also taught the same. And I had to unlearn what I was taught in medical school to be able to do this care. And I saw this as such an important thing, because I could recognize in my patients they're really suffering in midlife. So my patients in their 40s and 50s specifically,
Yeah.
they're at the peak of their careers. They're carrying so many responsibilities, and I didn't have anything to offer them because I was, again, taught not to. So it was a great unlearning for me. And it's been really beautiful because it's changed how I practice. I see the changes in my patients when I'm able to support them through this time in a different way than I ever have been. And now I'm teaching the residents and medical students in my program. And so we just taught a 3-hour lecture on menopause to our residents, and they loved it. And so I do think that the future is really bright.
The future looks brighter for sure. The fact remains there are currently, approximately 2 million Ontarians, so let's assume half of them are women.
Yeah.
For argument's sake, and maybe not all 1 million are menopausal, but I mean, we do not have access to primary care. So what advice do you have for women in midlife who really are carrying such a big burden with menopause symptoms and other issues? What can they do?
I appreciate that we're having this conversation. I think this is a really big starting point, is by raising awareness, we're closing that knowledge gap. And an informed patient is more likely to get that support that they need. And so by having these discussions, taking it in, taking notes, going to validated evidence-based resources, and knowing and trusting your symptoms. For too long we've been told not to trust our symptoms. Tracking your symptoms and going in informed will be very helpful. So for those of you who have a family doctor, I suggest going in informed, naming it, saying, I'm concerned about menopause, booking the appointment specifically for that. That is a great opportunity to focus that time and get that care. And if you're not getting that care from your own family doctor, you can ask for a referral. This is where it's challenging because there's long wait lists for this. For those who don't have a family doctor, this is trickier. I do think walk-in clinics are filling some bit of a gap, and sometimes they can help a little bit if you go in, again, informed and say, this is what I'm looking for, here's my risk factors, this is, if you know what you're asking for, it can be helpful. And you can also ask for a referral from a walk-in clinic. What's happening right now is that the space is being filled by private options. And so if you're able to pay for those options, that is an option that you can opt for, and there's virtual care options and in-person care. It's really hard for me to talk about those sometimes because I really wish that our healthcare system was able to serve everybody. Everybody had a family doctor. That is our goal. And eventually there's healthcare reform coming in that we're hopeful for. But again, that takes time, like you said, Beatrice, and it's going to take years. So what do we do in the meantime? We have to fill that gap somehow. And so that is where virtual care is stepping up. We're hoping to increase our access at Women's College for OHIP covered, or Ontario Health Plan covered services, to be able to do it virtually as well. So I think these things are coming. But in this moment right now, walk-in clinics are filling the gap, virtual care, and these private pay options. So, and I'm happy to share resources around that and options that may be helpful.
Yeah, we can put some in the episode notes.
For sure.
I feel very conflicted. I understand the why. You know, if there's a gap and you're not feeling supported in a system, there are people who will create the solution, but that solution needs to be paid for by someone. Where I find it so hard is that the someone is the patient.
Right.
And that is not affordable for everyone.
And this is where, full disclosure, I do work with a virtual care company, and they've decided their social justice piece is menopause care. And so as such, they're offering with corporations or with individuals, they're able to say, with a promo code, you get a year of free care, and we just want people to get access to care. And so that's virtual supports. And
that's good to know. We'll share that too.
And so I'm happy to share that because, again, going and doing these talks, having these conversations without having an access to care option, it's very difficult for people. And it makes me feel bad because I want to share this knowledge, but then if you don't have somewhere to go, it's difficult. So this service provider cares for people across the country. We actually just partnered with the Black Physicians Association of Ontario, who recognize that many of folks in their community struggle to access care, and it's free care. And so that is one option that is available. But again, not everybody is a candidate for virtual care. If you have symptoms that need to be seen, you still have to go and see somebody in person. And that's either a walk-in clinic if you don't have a family doctor, or you're waiting on a referral.
That's a good point. I mean, I know that you have done a lot of work in sexual wellness, and still remains, we're much more open about our symptoms of hot flashes and brain fog. I think the conversation is wide open, and we can talk about hormone therapy a little later if we want to review some myths that persist. But there are so many other issues, including sexual wellness.
Yeah.
Do you want to walk us through that? Because it is still so very taboo, and I don't think you can. How does that work with virtual care if you're having vulvovaginal symptoms?
Right.
I mean, don't you need to look at it?
No, not necessarily.
Not necessarily?
No.
Okay, walk us through.
So this is what's interesting.
Yeah.
So genital urinary syndrome of menopause is the complex of symptoms that are when the estrogen levels feed the tissues of the vagina, the bladder, the pelvic floor. And when estrogen levels decline, your tissue gets thinner. You may feel more dry. It can be uncomfortable to have sex or intimacy with self or partners. There's a whole spectrum of symptoms that happen in terms of the vaginal health. And then there's also the bladder health, where we see things like recurrent bladder infections happen, more frequent urination patterns or urgency. So that complex of symptoms is often undertreated because patients don't talk about it and we don't ask about it. And it's really on us to do that. So we are seeing our patients for Pap testing, or now it's HPV testing. We're doing these tests and we don't mention it, and our patients are uncomfortable. This is where I stop doing a Pap test and I say, I'm not going to do a Pap test if I'm not going to hurt you. We're going to treat this first, and I want to see you in 3 months. Once you're treated, your tissues are less uncomfortable, they are more well lubricated, and because there's options for treatment. And I'd say this is an area that is really under-discussed, and we have excellent treatment for people going through this. And I hope that if anyone takes any message from today, it's please talk about the vagina more. Sexual health and reproductive health, this is health
It's
care.
health.
It's healthcare. I see the effect that this has on my patients in terms of their personal lives, how they see themselves, how they perceive themselves, but also their relationships change as a result of difficulties with intimacy at times. And that is really important to address.
Do you want to walk us through some of the very effective things that can be done for that? Yes.
Of course. So it's my favorite thing to talk about.
Yes.
Because again, we don't get to. And I grew up in a home where we did not talk about it. Like if I'm on the social and I'm talking about anything to do with sex, I do not tell my mom that that's the topic. I talk about it, and I still need to get over that. This is where it's sort of like, I talk about this at work all the time. Why can't I tell my mom?
My children cringe that I'm on YouTube and Instagram saying things like wearing jeans hurts.
Yeah.
It's not just, we think of the vaginal tissue, the vulvar tissue, like as a vehicle for intercourse or childbirth, but I mean, it's just part of my tissues. And if I can't wear pants, or I have to stop biking because it hurts, your quality of life truly gets impacted.
It absolutely does. And this is where, again, sexual health is part of our health, and we have to see it as that. And what happens in menopause is that your tissues change so much that they actually can flatten out and start to disappear a little bit. So the vulvar tissues, the external genitalia change. But we have treatment options. And so first off, we always start with the things like lubrication and moisturizers. Those are non-hormonal options that are effective just for friction. That can be helpful, but they don't treat the tissues. What we need is to actually treat the tissues properly, and that is with local vaginal estrogen treatment. Very safe, minimal absorption systemically. So if you test your blood levels for estrogen, we're not going to see an elevated level of estrogen due to the local vaginal estrogen. And what it does is it nourishes the tissues and feeds the tissues to be well lubricated. The tissues thin out, it can thicken up again and make them more pliable, so flexible. So that helps with the discomfort, and helps with lubrication, and helps with your pelvic floor, and it helps your bladder health. And the difference with local vaginal estrogen therapy compared to systemic hormonal therapy is that you can start it at any time in your life. And I tell my patients, till death do you part. Because the moment you stop taking it, just like if you stop working out, you're going to lose your muscle, the same things will start to reverse again, and we need to continue it. So I start my patients, especially those who come in, and maybe sex and intimacy isn't what they're focused on, but they're having recurrent UTIs. My 70, 80, 90-year-old patients, I'm starting them on vaginal estrogen therapy, and they're stopping the need for recurrent antibiotics. It is life-changing and also life-saving, because bladder infections can lead, especially in the elderly, can lead to sepsis or kidney infections, which is a leading cause of hospitalization. And so if we actually properly treat the tissue, rather than just treating the recurrent UTIs, we're actually supporting people, keeping them out of the hospital, and potentially saving their life as well.
It's so shocking at how little awareness, number one, so that's what we're working on here. But when there is awareness, and I know because I have this time of the month community, and people tell me, I I approached my primary caregiver. I requested, and I'm not being offered this, the vaginal estrogen. I myself it was a lot of asking.
Yeah.
You know, when it should just be like,
Men
here.
go in and ask for
Yeah.
their ED medications, and it's sort of like a quick, hardly any questions are asked.
Yeah.
And I think it's the stigma around estrogen itself, and still the residual effect of the Women's Health Initiative study. And
Absolutely.
vaginal estrogen is treated in the same box. We have on the box, in the packaging insert for vaginal estrogen, so local estrogen therapy, it's the same as the systemic hormonal therapy level. So the same risks are attributed to local vaginal estrogen,
That's
which we
gonna
know
scare
is
any
not
user.
true. So some pharmacists will write to me and say, when I start somebody on full body hormonal therapy or systemic hormonal therapy and local estrogen therapy, because whole body systemic therapy, like the patches or the gels, don't necessarily help the vaginal or bladder symptoms. You need both, and they're safe to take together. Some pharmacists will write to me and say, hey, you can't prescribe those together. That's too much estrogen. So we do like a gentle note back, and we use it as an opportunity to educate. Again, everybody's learning right now. And then we shift those practices, which I think is helpful in the end. And so, you know, vaginal estrogen is very important and shouldn't be categorized in the same way. Recent studies also show like we can't use systemic hormonal therapy for our breast cancer patients who had hormone receptive positive estrogen, like estrogen positive receptors. But vaginal estrogen therapy has been found to actually be okay to use in those patients. And
that's another big myth.
That's a big myth, and that's a population that is often left out. Again, when we're talking about populations who are left out of the menopause conversation, are breast cancer survivors or cancer survivors in general, where they're told you can't be on any treatment options.
Yeah, just be happy you survived.
Exactly. And so there's a survivorship movement around we need to be addressing our needs as well. So we survived this, but now we are not living well and we're uncomfortable. And that's not necessary either. And that is a nuanced conversation. We always have those pieces, but I work very closely with my patients who have gone through breast cancer treatment, and I'm safely prescribing these options to them.
You know, I think it would be helpful. This is important. I think we need to spend more time here and really break it down, because I also have community members who, you know, the awareness, check.
Yeah.
Ask the physician, check. They got the whether it's systemic or localized estrogen or hormone therapy, and then they go home, and guess what? They're telling me it stays in the drawer because they're scared. So the fear persists.
Yeah.
Let's help that person. What would you tell her?
Please don't be afraid of local vaginal estrogen. It's about 1,000 times less potent than systemic hormonal therapy. It is not absorbed fully in the rest of your body, and studies have shown that it's safe to use. And so it is scary because you open the box and you get that warning label.
Yeah.
And so you're going to read it and you're going to see that. We're working hard to actually advocate to separate that out and not have that warning label because it is inaccurate.
Correct.
And that is a disservice to individuals. I also have patients, they come back for their PAP a few months later, and the reason why they didn't is because maybe the other reason separate from fear is that they're not familiar with their body. And so I have a mirror in my office that I say, do I have your permission to show you where to apply it? And that's something I didn't often do, and I didn't realize that my patient said, I don't identify with this part of my body anymore. I'm 65, I'm 70, I'm not sexually active. Can you walk me through it? And that's something that we do in the office, where I pull out the mirror with their permission and I say, this is where you apply it. And then they feel more comfortable and confident to do that. So certainly fear is one piece, and I just want to reassure people that those labels that are in that are not accurate. It's very safe to use. Very little is absorbed, and please do. The benefit that you will get from this is huge. It's really treating the tissues, and that's going to make a big difference for you. And then the other factor is comfort in being familiar with that part of your body. And for that reason, there's different formulations that are available. So for some people, they need an applicator and they want to use it that way. So there's an option for that. For some people, it's a cream that you apply on the outside and on the inside. They feel more comfortable. And for some, it's a suppository that you put in yourself. For folks who don't want to touch the vaginal area and are experiencing discomfort, there's oral tablet that we can use for pain with intercourse related to genital urinary syndrome of menopause. So there's another option for people. So there is an array of options. So it's not just vaginal local treatment. We also have an oral tablet for those who may experience that.
That's such a great clarification. I hope this gives a little bit of extra comfort for those, who now have it but are taking it. And those are the things we don't always think about, right?
No.
In the physician-patient encounter, you're like, okay, well,
we don't have a lot of time. I would say cost is an issue that we don't talk about enough in the doctor's office, and that's a big issue for a lot of people, is how much does a medication cost? And we should always be asking, when we are making a prescription for a patient and writing it out, tell me what your health coverage is. Do you have private insurance? Are you paying out of pocket? If you're paying out of pocket, it's really important to tell your clinician that, because there's many options available that are safe, and we need to know that. Otherwise, we kind of get social. Again, what we learn, we quickly prescribe it. It might be the most expensive option when there is actually a very good option that is a little bit less expensive, so you're more likely to be able to fill that prescription. But that's a big conversation that's left out of the picture. So our pharmacist colleagues are really great at that. Like, I appreciate that when they send something back and they're like, this is another option for your patient. Could we use this?
Yes.
It is $30 less expensive per month. $30 goes a long way for a lot of folks. And so if I can offer that to them, that's a big changer. So I know cost is like we talked about sex being difficult to talk about, but certainly finances are a hard thing to talk about. And there's a lot of taboo around addressing that. And what I work with, we are really fortunate at St. Mike's, we have an income support team. And so we refer our patients into that team as well. And they work with our incredible team who help them navigate doing their taxes, making sure they're applying for their tax benefits, applying to drug benefit programs that allow them some cost savings in that way. And there are programs like the Trillion Drug Benefit Plan for people in Ontario specifically. If you are not covered by anything, this will help you reduce your medication costs, especially things like hormonal therapy.
That's really important to know. As we continue the topic of sexual health, you've talked about the vaginal estrogen. I do want to talk a little bit about testosterone because that is even less well understood. And I think right now there's a lot of, I don't know if it's conflicting, but confusing information. And people are making claims about what testosterone can and cannot help with. So can we start with what it helps with, and under what circumstance would you be a candidate for testosterone therapy?
Yeah, that's a great question, because it's actually not as, I thought there's a lot of information and disinformation around testosterone and a lot of claims around what it can do. So what specifically testosterone is indicated for based on the current research, and we just had in the last International Menopause Society meeting, Dr. Susan Davis, she's the world foremost expert in testosterone specifically. She said there hasn't been really a change in what we know about testosterone at this point. It is specifically useful for a condition called hypoactive sexual desire disorder in postmenopausal women. So that is a condition where you have a persistent decrease in desire or libido in your postmenopause stage. And specifically, that's all it is useful for, based on what we know currently. Now, science is beautiful. It changes and evolves, and maybe in a few years we'll know something different. But at this time, this is what we know. And so the claims of muscle mass, energy, all of these other pieces do not translate in the science right now.
Okay.
Like, we don't see that in the science. Many people do feel that they feel better on testosterone, and that's wonderful if you do, but specifically when you're seeing somebody, the reason why we will prescribe it is specifically for the loss of libido that's affecting your function.
I actually have the paper here. Is this? I believe this is kind of the go-to article, the safety of testosterone therapy in women. And I guess my question is, okay, so postmenopausal, so that means you're 12 months without your period, and hypoactive sexual disorder. It sounds very medical, number one. Dramatic, number two. And where's the scale in that? Who decides?
Our patients. So it's really important if you are I think this is something that we dismiss.
Yes.
And we say, well, everybody loses their libido at some point. And I have patients when I'm doing their PAPs, we use it as an opportunity to have these conversations because we're talking about intimacy and their vaginal tissues. And often they will say to me, oh, that's like I just thought that was done after menopause. And it's not. Actually, we know that sexual function and pleasure can improve after menopause for many people because some of the stresses around pregnancy, worry, and otherwise are gone.
Yeah. No kids in the house.
No kids in the house. And all these factors come into play. So if you are noticing that you have a loss of desire and you're just not feeling it, and it was something that's important to you, and it's affecting your relationship, and it's something that you want to address, that is enough to come in and talk to us and say, I need some help with this. And we want to, the challenge is that desire or libido, it's multifactorial.
Yeah, is it just because you're annoyed at them, or is it because you actually need a little hormonal help?
Right, exactly.
How does one distinguish?
No, and this is exactly it, where I think we certainly, and it goes in waves.
Asking for a friend.
So this is, yes, exactly. So I also ask for a friend often for myself. But this is what's really interesting. So if it's persistent, so certainly like we have moments where we don't want to be touched, we want to have our own space, we have this. I would say when I work with my patients, I say, is this something that's persistent for you? How is it affecting your life? Does it affect you when you're with somebody and also when you're on your own? We talk a lot about self-play in my office because I think that's really important. I have a vibrator box to show people like the different types of toys that they can use and loops that they can use. And they say, listen, we always start with like, how do you feel in your own body when it comes to sexual intimacy? And when they say to me, there's a persistent change, it's not just a weekend thing, like one weekend I want to, one weekend I don't, and it's affecting their relationship or their sense of self, that to me is enough to kind of go through and say, there may be an opportunity here to improve things with the testosterone. We also always have to think about, again, going back to the vaginal health and genital urinary syndrome and menopause, why is the desire decreased? So is it a relationship issue? Is there something going on that's changed for you that has affected your desire to be with this individual? Is it pain? Are you having discomfort? Because all the testosterone in the world is not going to change.
The desire,
Exactly. It's not going to change that you have pain with intercourse. Is it that you have a history of trauma that is coming up now? Again, midlife can bring up a lot of things that live within our body that we didn't know necessarily that were there. And is this affecting your ability to lubricate, to feel comfortable in this, and to feel safe? So it's a very thorough review of history and understanding the different factors that come into play when we talk about libido. It is not just it comes and it goes.
Yeah.
There's so many factors that play into this, and so we do have to distill it down a little bit and understand. So if it is pain, I want to treat pain and see. And we also have a different formulation called Intra-Rosa, which is a vaginal testosterone, or DHEA. That's another option that we can use that also helps. It converts into testosterone and estrogen vaginally. It's a really good option as well. So then separate from testosterone.
Right.
So always we have to look at the reasons. Why is it happening? Treat the underlying causes. Is it because you have diabetes and the sensation has changed? Is it a medical?
I bet you that's
is it
not
medically
even something
related?
that is.
No. Is it related to the medications that you're on?
Yeah.
Is it related to something I've given you? So is it related to the antidepressant medication that we're using right now? Because that will decrease your libido. And if it is, I have other options in my toolkit of antidepressant medications that may be more helpful and don't affect your libido in the same way. So this is where it's really important. It's a big conversation, but I want to go through medications. I want to go through medical history. I want to see what's happening in your relationship. And then alongside my colleagues who are sex therapists or pelvic floor physios, that's who at the National Menopause Show we did. That's why I said we have to have a panel on this. It can't just be me.
That's right.
It is a team effort when it comes to this. And meeting with a pelvic floor physio, meeting with a sex therapist alongside your clinician, that's where we really see changes happen. And certainly testosterone is part of our toolkit, but it's not the only thing. And it's important to recognize that there's multiple things that we need to do for this.
Dr. Sheila, I hope that doctors tune into you, not just our peers who are patients, because I think if there's already reluctance on just, let's call it plain old menopause hormone therapy to treat the hot flashes and night sweats, going to that next level of addressing the sexual wellness, I think is not well understood. I've even heard from community members that some primary caregivers say it's out of their scope of work. But whose scope is it then?
It's family doctors.
It's family doctors.
And this is where, as a family doctor, I also feel deep sympathy for my colleagues
Yes.
who are carrying a lot. There's a large amount of burnout, especially post-pandemic. And so we're managing again. So we go from room to room and we're seeing our patients and
Cradle to grave.
It's not to excuse that we are that we should be doing this work, but it is really interesting to understand. Like I'm seeing a two-day-old, and then I'm seeing my 95-year-old, and then I'm going over and talking about menopause, and then I'm doing a pap test. And so there's a lot of different things that we're doing. It doesn't mean that we shouldn't be doing it because we are capable, but there's a lot of stretch happening right now in the healthcare system, and we all want to do our part. So again, I think it's not our patients, it's not only on our patients, like it's really on us to make those changes, to learn and to do this. I have an upcoming seminar for our residents on sex because we did the menopause one. They were super excited. So now they're like, can you do a 3-hour seminar on sexual health? So again, I do think this is shifting.
Yes.
But we need to come in as patients also and ask for this. And if you know what the concern is, and you can say, I listened to Beatrice and Dr. Sheila on this podcast. This is what I think is happening.
Yeah.
What do you think? It puts us in a position to be like, okay, we have an onus to support you. Now, if patients are turned away, we then have to look at other options again.
Yeah.
And you mentioned like, can virtual care be an option for genital urinary syndrome and menopause? It can be so what I suggest to people, I say, we can start somebody on treatment virtually, but if they have persistent symptoms, that requires an in-person review. So if you are still having symptoms, because there's other complexes of things that can come up that do need to be seen in person, like skin conditions or nerve issues or otherwise.
Absolutely. If you are deflected, turned away, whatever the word is, this isn't about bashing our doctors. What I'm looking for, though, is sometimes asking for a referral.
Yeah.
Referral to who? You're just not going to get it. As a physician, now you're a very open one, clearly. That's why you're here with us today. But give us advice on how you can push back in a way that supports the relationship. It's a relationship, the patient-doctor one.
Yeah.
But there still is that authoritarian, if
there's a power differential
there's
in
a
our
power
office.
differential.
Yeah.
So how can we push back in a way that it's almost putting the physician at ease? Like, hey, I'm aware that there's this guideline.
Yeah.
I heard Dr. Sheila, I heard Beatrice on TTOM, or there's a Menopause Society guideline. I think we can do this together. I mean, that's what I'd like to say. But
I love that. I think that's a really wonderful way of doing this. Like, I mean, you printed this off. And so this is a validated space. So when my patients come in and they're like, I Googled this, and they bring in a stack of paper, that's tricky to navigate, right?
Yes.
Because I'm sort of like, I really depend upon guidelines, and I depend upon, and that helps guide my decision and have nuanced conversations with my patients. So if you're coming and you say, I went to the Menopause Society or the Canadian Menopause Society website, and this is what I found, I'm concerned about this is what I would like. Again, that will stop your doctor or nurse practitioner and be like, okay, this is somebody who is understanding that these are the standards of care for treatment, and you're more likely to get that support. So I think what you said was actually perfect, and it's a way we have to advocate for ourselves in the healthcare system. I wish it wasn't so, and I always end up apologizing for our healthcare system because I think we can do so much better for our patients. I do trust in my colleagues, but I also know that everyone's really strained. So I think we need to use our voice. We need to advocate for ourselves. Going back to the beginning of our conversation, the healthcare system is not safe for everybody, and not everyone is treated the same.
People can't advocate. They fear it.
Very
they fear
much.
it, yes. Self-advocacy, it's a big word, and we kind of assume everyone can do it. And not everyone is comfortable using their voice. Not everyone feels safe doing that. Or sometimes you might even fear repercussions of speaking up for yourself.
So I think this is very true, and I think sometimes people get turned away and told that they can't come back to some doctor's offices, and that's not okay.
Yeah.
And so those are reasons and we have a college of physicians and surgeons, there's reasons why we have protective mechanisms in place for patients who are not treated well in the system. For this reason, I created an acronym around self-advocacy, specifically around menopause, that I'd love to share.
Absolutely.
I'm going to use my phone because I am in my
yes.
perimenopause and I have a little bit of brain fog around this. But it's specifically, so it's called the PARTNER acronym. So hopefully like we're partners in healthcare.
Yeah.
And so the P is to prepare for your appointment. So what we talked about before is like when you are informed, you know what your symptoms are, how it's affecting your life. That's going to be helpful to you because again, you have 10 to 15 minutes maybe, and you want to be able to be efficient in that visit. So really using that time to prepare ahead of time, taking those notes with you can be really helpful. The A is asking for the right support. So if your family doctor or nurse practitioner are not menopause comfortable, asking for that referral or bringing those resources in. If they're open to learning with you, then bringing the resources like the Testosterone guide or something from the Menopause Society, that will be helpful to them. There's a Sigma Menopause guide I'll give you for the resources.
Yes.
That's a really wonderful tool that you can take in with you and just be like, listen, let's do this together because I want to work with you. And again, if they're not comfortable, you can ask for a referral. R is recognize your rights as a patient. So we have rights as patients. You have a right as a patient to ask for the care that you need, get that support, to not be turned away. And so use that understanding to recognize that you can say, this isn't really working for me. I'd really like to see a specialist in this area or someone who can help me with this. Can you do that? And they should be able to make that referral for you. T is talk about the hard things. So T is those things that we talk about. This is around self-advocacy because talking about cost of medications, talking about sex, those things that we don't often talk about in the doctor's office that really influence, these are the social determinants of health.
Yes.
The things that really affect our health in the long run are finances, housing, access, employment, those sorts of things. I need to know that as your clinician so that I can make sure that I'm prescribing you something that you can afford, or I need to know that you're struggling with sexual intimacy and you don't know where to put your vaginal estrogen potentially so I can help you. All these things. So talk about the tough stuff. N of partner is knowing your numbers. So numbers are really important. So your role as a patient is also to know, like, what's my blood pressure? What's my blood sugar? Often you're just told it's normal, but actually knowing the number is really helpful so that you can track it over time, right? Like, we all too often we're like, you're normal. Okay, what is normal?
Yes.
Right? Like 125, 185, is that okay? Good. Write it down, keep it a file for yourself. That's a way of empowering yourself with your knowledge of your own healthcare needs. The E is to ensure that it's not just menopause. Far too much, we go in and some doctors will be like, okay, hormone therapy seems to be the hot thing. Let me just give you your hormones and send you on your way. If you're having symptoms like palpitations or otherwise, that needs to be checked out. It is our responsibility as your clinician to say, yes, this could be hot flashes, absolutely.
But rule out.
Heart disease. Again, heart disease risk factors increase in midlife. We want to make sure that we're doing due diligence in that. So ensuring that it's not just menopause. And R of partner is to review all your options. So certainly it's not just hormonal therapy.
I love that. Let's review what are all the options.
Lifestyle options, non-hormonal therapies, hormonal therapies, systemic hormonal therapies, local hormonal therapies. There are many options available. So review all of them. And then if you go in informed and you know what those options are, that's also really helpful. Recognizing that the healthcare system is not safe for everybody is very important because this acronym may not apply for everybody, right? You're going to try your best, but if you don't feel safe or you've faced discrimination before, you're not even going to want to walk through that door. So if that's the case, I think it's really important that we acknowledge that. Systemic racism, anti-Black, anti-Indigenous racism exists in our healthcare system. It affects people's lives and it has caused death in some situations. Yes. So we need to protect those patients who are most affected. So I always suggest bring somebody with you if you can. Having somebody else in the room who's there to advocate alongside you can be really helpful and hopefully increase that safety that you may feel. And then just letting your clinician know. So if I'm making a referral to a specialist, I know that you've had a negative experience in the past, I call ahead to that clinician's office and I say, this patient needs a little bit of extra support. And often they're really receptive to that. They just need that heads up so that they're going to give you that a little bit of extra time, or that when you come in, they're going to give you a space that you can calm or do some breathing exercises. There are options available. We just have to know what's available to us. So I made this acronym just to help people kind of guide through how to go through a menopause visit. But I think it's, we have a lot of work to do in the healthcare system to make it a safer space, but hopefully this is a start.
Speaking of the R and review all your options, there seems to be fear of missing out, FOMO around hormone therapy. Social media again, is it the silver bullet? What if I'm too old, too late? Can you walk us through that and put everyone at ease?
Sure. So absolutely. There's a lot on social media that says if you don't have estrogen in your system, you're going to shrivel up and die. And that's a really unfair statement to make. And that is a huge claim. Not everybody can take hormonal therapy because of a medical condition that doesn't allow it to happen because of the risks that may be there. Not everybody wants to be on hormonal therapy because they choose not to. And some people can't tolerate hormonal therapy, so they try it and they have side effects to it, and it's not something that they can pursue. I think it's a real disservice to people to say that you have to be on estrogen therapy or else things are going to go really downhill. There are many options available. I think that we have to be really gentle with ourselves and understand that because you can't be on hormonal therapy, it's not going to be the end of the world. Many people have survived and done really well without it. And we also have excellent options that are non-hormonal that are available to you. So we have things like medications that target sleep and mood. We have a new medication that's available now for hot flashes. That's a non-hormonal option. It's a game changer. We've been waiting for something like this. As science evolves, there's going to be more and more of these things. And so I appreciate this question because so many people come in and they'll say, I don't want to be on hormones. I don't like the idea of hormones. I have a family history that makes me worried about it. So we walk through it and we say, okay, well, what is comfortable for you? It is a shared decision-making process that has to happen in every visit around what is comfortable for you, what is the right fit for you in terms of your medical history. And hormonal therapy is not the only thing that's available.
And I remember our initial conversation in terms of it's not one and done.
No.
So, and also Dr. Jessica Green was on early in our show, and it's not a tattoo. So something could have worked a few years ago and now needs review. Even on hormone therapy, for example, it can help alleviate hot flashes, night sweats, but what happens when they sort of come back and get aggressive again? Is it a dosage issue, or is it what
could be?
What's
right?
an
So
example there of what can be done? Yeah,
exactly. So this might be a dosage issue. Our health changes as we get older, so every year we do a yearly check-in after you get to a stable dosing of your hormone therapy, and I want to make sure that your heart disease risk factors are being managed. Check your blood pressure once a year, making sure that all those things are there. If somebody's symptoms are coming back or getting worse, we need to adjust things. So is it that we need a higher dose? Do we need to try something different? I just recently had a patient who was really excited to start on hormonal therapy, was ready to go. She started it and she started having side effects to it. So I said, come, let's see what else it could be. Maybe it's the progesterone component. Maybe we can use a different progesterone. Maybe it's the estrogen, how it's being given to you. We can try, instead of using the gel that we prescribe, maybe you need the patch. And so there's ways that we have to fine tune things. It's a nuanced approach. For many people, it's quite straightforward. We start it, you feel better, you're good, and you go. But for some folks, we do need to do this nuanced approach where we're adjusting the doses, making changes, and going from there. So it's not a one and done. It is definitely a process and an evolution. And as we learn more, we're able to offer more as well.
Being with you on this couch is not only a breath of fresh air, but I feel an urge to act. What can we, as citizens, as peers, as viewers, and some of us have the ability to use that voice to advocate for change. What can we do? Because it shouldn't just be the physician community asking to change, say, education in the medical system, or implore, our public health system to create billing codes, for example, or whatever it may be. What can we do?
I mean, I think that's just it, is using your voice, yelling it from the rooftops, saying women's health is important, menopause is important, we are 50+% of the population, and it affects us in all different ways, and asking for that change. So when it's time to decide on who we're going to be having as our leaders, ask them those questions. How are you going to ensure that every person in Ontario, every person in Canada has a family doctor? How are you going to ensure that that we have a national pharmacare plan that includes, like Manitoba just passed it.
Yes.
And so menopause hormone therapy is on their pharmacare plan, and that should be across the board. how do we make those things happen? It's with the voices of the public speaking up and making these changes happen. It is on all of us, not just, as you said, on certainly it's our role as healthcare providers because we're seeing this firsthand, the effect on our patients' lives, but it is on all of us to advocate for our communities, and especially for the communities who are underserved and their voices are not always heard. So how do we do that? How do we make sure that everyone is lifted up? Using your voice, voting for the folks who are going to make those changes happen, and advocating for change. So letter writing, talking to the medical schools, talking to the residency programs, because that is where change will happen. We are fighting for that, but we're often turned away because they're like, we'll focus on this and we'll get to it. There is a loud menopause movement happening right now, and there are changes happening. So I'd say 3 months ago, we approached the university to say, we need to create a menopause tool for family doctors across the country. How do we do that? And they're like, we're not sure if our funding's going to allow it. But now I just had a meeting with them this last week, and we're creating that tool. And it's because they have recognized that there is a public outcry for menopause support, recognizing the role that primary care can play, and now we have the funding to create this tool. And that is not because we are doing that as physicians and nurse practitioners asking for it. It is because of the loud voices of women in midlife who are like, we're done. This is not fair. Yeah. I don't want my daughter to have to deal with this in the same way that we are having to fight for this access. 6% of research in Canada is done on women's health issues. We need to change that too. So it's knowing those things, and then letter writing, calling your offices of your politicians, calling the institutions that educate our future clinicians. So not just family doctors, but also nurse practitioners, specialties, everybody. We're all in this together. Pharmacists too. We're all part of this. And moving on that. I think that's really wonderful. And you have an incredible following of people who have voices. And so let's do this together. There's something so important in the sense of community in doing this work that will make change.
And also, you know, it's because of these beautiful voices that we have. You know, there are quality standards being created right now.
Yeah.
I'm not sure by the time we air this episode if they'll be published for public consultation, but that's also an opportunity for people. When these things get disseminated, the public has an opportunity to comment.
Yeah. And when we talk about change, certainly there's systemic level change. Yeah. And then we have to think about the individual changes that we can make in our own lives with the people that we care about in our communities. So just as important as raising your voice and advocating at the systemic level with your politicians or with these institutions, it is also important to advocate for the people in your life and your community. So sharing this episode, talking to the people in your life and saying, your mom has been having recurrent UTIs. There's a treatment for that. That's not just antibiotics. Or like having these conversations, having these discussions with groups of people together, that is actually what's going to change people to feel more confident and to be able to come in and ask for that support, is knowing, just like we talked about with my group of 3 women in my Indigenous outreach clinic that came in, together we are more strong and more powerful, and we can make those changes for everybody in our community.
Do you think everything you just named is part of how we will get to a point where we don't necessarily have to self-advocate, or do you think that will always exist?
I think I'd like it to be less hard.
Yeah.
I think that will change, hopefully. I'm hopeful. I'm an optimist around these sorts of things, and I think that's important to maintain that. I think that self-advocacy is always going to be there. We always will need to advocate for ourselves. It's a tool. I think that's something that we have to actually maybe teach in schools, is just like in sex ed or otherwise, we are teaching how to self-advocate, not just in medical settings, but in all settings.
All settings.
And how do we do that? We have to start young. So my kids hear the word vagina and menopause more often than they probably expected to. And my parents are like, oh, they know their anatomy. I'm like, yeah, they have to know their anatomy, because that's how they protect themselves. This is how they advocate for themselves. So we start young, and we keep on affirming that message as we get older.
I love that message. So what else do you want the audience to really take home?
So I think, suffering is not an option anymore. Let's know that we don't have to suffer through these symptoms. They have great options available. And if by knowing what your options are, you can get that support, hopefully. I think sexual health is a really big piece of what the work
Yes.
that I do. So let's talk about it. Let's normalize the conversation and understand that by addressing it, it can improve your health overall. And finally, I just think it really goes back to that advocacy piece. I really appreciate that you're offering me this opportunity to talk about equity and advocacy. The menopause space specifically has tended to skew towards sort of a population where it's important, all of us need to get menopause care, but it's leaving out folks of the conversation. We didn't talk about non-binary and my non-binary patients and trans patients who have a different experience of menopause potentially. So we need to think about all of these different populations and advocate across the board so we can make change and lift all of us up. So I think those are the things that I would suggest that we focus on.
Thank you so very much. I felt as I said, your humanity when I first saw you on stage and I saw your beauty radiate. I'm just curious, what does make you feel beautiful, Dr. Sheila?
Oh, I mean, I think conversations like this, like I get teary thinking about this. I
I'm
think it's so
teary.
beautiful. I think when I see my patients who have struggled quite a bit and I see them thrive, that creates like this energy in my body. Oh my God, that I find beautiful. Like it's like this shared humanity. Like I see them, they see me. I cry often in front of my patients, and I'm just sort of like, we're human together. Like let's see each other. Like we are humans. We suffer. We celebrate together. We suffer together. Like let's connect, and that's really like a beautiful thing to me. And I feel like that.
I think it's so beautiful, and this is why I really wanted this couch, because I wanted we need to break the barriers between patients and physicians and accept that we are both humans. So thank you so very much for coming.
Thank you.
Part of my relaxation routine is to light candles. I love reading a book, listening to music, just some me time. There's nothing more frustrating, though, than grabbing my lighter and finding out it's out of the butane gas. And so, what do? I discovered Sizzler lighters. They are not only very beautiful, they're rechargeable. You can recharge them with your USB cable and never run out of lighting power. There you have it. You never run out of gas.
Thanks for listening today. This podcast is for entertainment and informational purposes only. The content shared here should not be considered professional medical advice. Always consult with a qualified healthcare provider for personalized medical guidance. We're here to empower and support you, but your health decisions should be made with your own medical team. Until next time, take care and keep thriving.